Start by Lou. Let everyone know they're being included. Do you feel included, everybody? And those that were supposed to be here online and aren't, you're not included. But thank you. Thank you. Thank you to the Matilda team for coming. Kevin's running around. He'll be back in a minute to present, I hope, or at least have a chat. And we will get going. I can do all that, mate. That's my job. I'll start. You'll start. Thank you. You do have to kind of like sit here so they can see you, and people online will see you, but they're not online, but it's a better way of doing it. And thank you for coming. Thank you for doing this.
Thanks for having us.
Thanks for having us. Keep an eye on time. Hi everyone, I'm Jo. I'm one half of Matilda and I'm a pelvic health physio by background. And I'll let you introduce yourself.
So I'm Kevin, also a physiotherapist. That's how Jo and I actually met at a clinic in Perth probably 7-10 years ago, something like that.
10 years ago.
I did my PhD in low back pain, recovery from low back pain, and understanding how movement and posture and psychological factors relate. And we both have a bit of a passion for kind of using technology to make care more effective and more accessible. So that sort of led us to a grant. That part of that grant I wrote in there to try and make sure we had regional and rural representation and engagement. So that's kind of what kicked this off. And I reached out to Zara and Lon and a whole bunch of clinicians up here and Lauren to organise that. So thanks all for coming, and kind of want to keep it relatively informal. We've got some presentations from various clinicians, some of those which are sort of pre-recorded videos, but there's also some time to mingle and hopefully kind of connect with each other. Does everyone feel like they know each other in the room? It's sort of, I'm running an experiment, so you'll see when it comes up, but yeah.
It's a little surprise and delight later. So I want to start.
Oh yeah, so you have to press.
Yeah. Worked out the tech. I'd like to begin by acknowledging the Yawuru people of the traditional custodians of the land on which we gather here in Brook. We pay our deepest respects to elders past, present and emerging, and extend that respect to any First Nations people in the room today. As we know, Aboriginal and Torres Strait Islander people have been living healthily, learning and looking after each other on country for at least 65,000 years. So we wish to acknowledge this ongoing contribution. I also want to acknowledge those with lived experience of pain or chronic health conditions, and anyone here whose health is not what they want it to be, particularly if it's endometriosis or pelvic pain. So I think we don't have to do too many formalities. Does everyone know where the bathroom is? Perfect. There we go. And emergency exits, yeah. And if you're hungry throughout, feel free to eat all the food, because we have eaten a lot today of what was left over last night. And I think there's only so much we can continue this happening.
It's very much avocado, so takes one go.
Yeah. So before we begin, I just want to tell you a little bit about the word Matilda. So Matilda means strong in battle in Latin, which is why we're called that, because we recognise the strength that it takes to face a journey that may not be by choice. We also touched on this, acknowledging our grant that we received from the Future Health Research and Innovation Fund that allows us to come to rural and regional communities and talk about these things. So we pondered about this a lot, about what accessible care means, and it feels like a bit of a buzzword. It's in lots of grants at the moment, accessible care and things like that. So we wanted to actually talk about what does that really mean. And so we talked about it really being local knowledge and culturally safe support, and feeling seen and supported without the need to leave your community to get the help that you deserve. So we know that it's more than shorter travel times. That's part of it. It's involves, care that fits around work or the family demands or the demands of the community. So actually looking at that as a whole instead of thinking of it as just a distance factor. Kev's going to talk about this one.
Yeah, and sorry, there's the conversion from Mac to Windows is messed with some of the.
I've got a PowerPoint Mac to Windows. It's been on a journey.
But I just wanted to share some of the results from last night. We want to report back to, well, we have to report back to the grant funding bodies for this. And part of our goal is to obviously educate you and increase the networks and understandings of the various clinicians that are available at your resource here, but also virtually and online. So we collected some outcome measures, and we'll do the same with you guys shortly. Before and after the event last night, we held a community event at the Surf Lifesaving Club. And yeah, it was highly rated, and a few words from there really helped to have support and an event all the way even up in Broome. It's great to have a variety of different perspectives: mental health, physio, yoga, diet, thank you, feeling more educated with endo, easy to understand, upbeat, felt welcoming. The co-founders knew how to engage with the audience, and we sort of collected some measures in terms of understanding their symptoms, access to services, confidence in management strategies, empowerment to take an active role, and knowledge of treatment options. And we saw quite large effect sizes for that in terms of improvement in that after the session. Next slide is just the actual effect sizes. As I mentioned, but just to say, so that it's clinically or statistically significant, the 95% confidence interval doesn't cross the 0. So we can say that we had a positive impact on the people that attended last night, which is obviously what we're trying to do. And quite a large effect size. The co-handing was quite large, which is now brings us to your turn to
scan this
survey. So please keep your phones out, scan it.
We're reporting back to the government. Is what Kim says. Last time we wrote this, I feel like
Funny, I sort of wrote the slides, and then Joe's like on the fly.
It's a bit heavy. Yes,
So it's all anonymous as well.
Yeah.
So you're
not putting a name to the government.
we won't if there's
Our names.
it's just
Our names back to them.
it's 4 questions. It hopefully doesn't take too long. It's not like doesn't matter.
It's fine. Took me a few guys to work out what it is. No, I think we're okay. We just get it down.
Is it easy? I've done it.
I love it. I'm okay. Yeah.
Yeah, I'm sure.
I'm on like 5%. Yeah.
All right, everyone's
All right, I'll introduce Lauren. So Dr. Lauren Hart is an obstetrician gynecologist and specialist pain medicine physician with expertise in pelvic pain, endometriosis, and minimally invasive surgery. She trained in Sydney and Newcastle, completing advanced laparoscopic and hysteroscopic skills at the Royal Hospital for Women, and now practices here in Broome. I'd like to welcome Lauren up. Yeah. Well, thanks for having me. So 5 minutes is a really short amount of time to talk. So we'll start suddenly and end abruptly. And I'll try to squeeze in as much as I can. So having said I could do okay, there's that. So I'm going to give you 3 of the most important takeaways that I think we can do in 5 minutes. But I wanted to start with this, that if someone presents to you with pain, then the most important thing is to really hear their story and validate their experience. Pain is an experience. I can't feel yours, you can't feel mine. What you tell me is what I should believe, and you shouldn't have to prove to someone that you have pain. And actually that time listening to people and letting them tell their story is something that for some people that's something that no one's done before. So just some stats. Endometriosis is estimated to affect in Australia 1 in 7 women or people assigned female at birth. Persistent pelvic pain, which is pain occurring below the level of the umbilicus, lasting for 3 to 6 months, depending on your definition, is estimated to affect between 10 and almost 50% of women in their lifetime. So you average that, I think, about 25%. So 1 in 4 women will at some stage in their life have persistent pelvic pain. Period pain, estimates vary widely, but could affect as many as 95% of people who have periods. So it is a very common thing, but that doesn't mean to say that it's something that we should treat as normal. And then dyspareunia, so pain with intercourse, is estimated to affect around 14% of women in their lifetime, maybe as many as 35%. So my first take home is periods are not necessary unless you're trying to have a baby. Otherwise, you don't need to bleed every month. Yes, there are pros and cons to being on hormonal contraception, but there's no downside to not bleeding. And contrary to quite a widespread opinion, you don't need to have a break every 3 months or 6 months or 12 months and have a bleed. So even though you can argue that the hormones that we use are not natural, and they're not, and they have side effects, we're probably not designed to have a period every month from the age of 13 to the age of 50. Our bodies have been used to for thousands of years having babies and breastfeeding and doing that over and over again. It's actually a pretty intense physiological process when you look into it, having a period. A lot of pro-inflammatory chemicals have to be released. The lining of an organ has to be grown and then shed and then crumpled and then squeezed out. And doing that repeatedly, particularly if it's painful, can lead to more pain. So what we know about not having periods is that skipping them altogether seems to give better symptom relief overall than having a regular bleed. So while it can be beneficial to go on the pill and then bleed once a month, and you might have a reduction in your period pain and a reduction in the heaviness of your bleeding, you probably get better symptom relief if we can manage to get you to not bleed at all. And then, yeah, just going back to the first point there, medical treatment is treatment. And I just really want to make this point because sometimes people feel that they're not being listened to and not being validated when they see their GP who says, I hear what you're saying about period pain, let's try a pill. And I want that message to be that, no, we are hearing what you're saying, and this is a treatment option. Okay, my next point. So pain should be treated. So even though we can say the stat that maybe 95% of people will experience period pain, it should be considered a problem if it's disrupting your life. If you're missing work, if you're missing school, if you're not socializing, if you're doing all those things but you're not really present because you're uncomfortable, you're suffering with your period pain, then it needs attention. So we should pay attention to that, but then we should also think about other things that can be going on in the pelvis and elsewhere that could be contributing to your pain. If someone has a diagnosis of endometriosis, please don't stop there. Please don't say you've got endo, that's the cause of your pain. Let's stop looking elsewhere. Because what we know is that 8 out of 10 women who have persistent pelvic pain, endo or not, will have some form of pelvic floor dysfunction that is amenable to treatment. Bowels are really important. Probably more of what I see is constipation rather than loose stools, but definitely I would see that as well. And I can't tell you the number of times when people have said, I don't go very often, but I've been told it's normal for me. Opening your bowels once every 2 weeks is not normal for anyone, and it needs to be addressed. And then the third point, even though there are other things I would say as well, is to think about central sensitization. To talk to people early about this concept of your pain system being heightened, of being overprotective and sending off signals at a higher volume than it needs to be doing. And that is also amenable to treatment. And then my last second point is about surgery. So if you are looking after someone who's thinking about surgery, then the things that I would encourage them to talk to you about or talk to the doctor who's going to do the surgery about is what are they expecting? And this is really important. Are you expecting that because you have a lot of period pain and a lot of pelvic pain, that we're going to go and find endometriosis? And we might, but we might not. And sometimes that, when we don't, is devastating for people. The most important thing is that their experience is valid. Whether or not there's endometriosis does not change the fact that they have pain and doesn't change the extent of their suffering. And the amount of endometriosis we find doesn't change that either. And then the second thing is what happens if we find endo and we treat it? Outcomes are variable. Our evidence for surgery really needs to be beefed up in terms of quality and quantity. But what we know is that some people will get improvement, some people will have no change, and some people will be worse after surgery. So talking to people and making sure they're aware of all these possibilities is really important, and talking to them about long-term management as well. So a lot of studies that look at the impact of surgery don't necessarily talk about the marina that was put in at the time of surgery, and that's a really important thing as well. So they're my 3 take-homes. And then this last slide is just from the RANSCOG Living Evidence Guideline for Diagnosis and Management of Endometriosis, which at first I was not super keen on, but I actually really like it now. I like that it says at the top, consider other possible contributors. Oh, sorry. And treat them early and refer early. So refer to your pelvic physio, refer to your dietitian. Start symptom management right at the top. And you can consider diagnostic investigations concurrently. Not everybody will need to have diagnostic investigations straight up, particularly if you have someone really young. They don't necessarily need to have an ultrasound. They really don't need to have a laparoscopy as a first port of call, but starting symptom management and then thinking about what else needs to be done at the same time is the recommendation. And that's it.
Fantastic.
Fantastic.
Lauren's going to duck off, so I'm going to do questions with Lauren now. So I'll open it to the floor.
What's first? Is first line hormonal treatment being the pill?
It doesn't matter, any hormonal treatment, but you can also talk about non-hormonal treatment. So even though our best evidence in management of endo, management of pelvic pain is hormone medication, but if someone doesn't want to, if they're trying to fall pregnant, it's not appropriate. Then talking to them about lifestyle changes, talking to them about analgesia options, using stuff like tranexamic acid to reduce flow. Yeah, like you can definitely talk to them about that stuff too.
Just because it says first line hormonal treatment.
Yeah, no, it
Like
doesn't
the
say
same
it.
white first line hormonal treatment.
Yeah, if someone wants a marina, it's a marina.
Then what is second line hormonal
Like a different thing to the first one.
treatment?
So, you know, if you start someone on Wernli and they come back and go, I feel terrible on this,
Yeah.
then try, fluoxetine.
Okay.
But yeah, right. We always talk to people about there's 16 different versions of the pill in Australia, and we might not get the right one the first time. And so trying a different one with a different progestin or a different dose, or, you know, in the case of Zolio, you know, a different estrogen, we might get one that suits you. Sometimes we don't. That's really frustrating. But if you just try one pill once and say it doesn't work for me, then you probably haven't done yourself the best service. And the other thing to say is, it says you try it for 3 to 6 months. I would say only 6 months if someone's tolerating it, because for the first 3, you might not even be getting good relief of bleeding. You might not have achieved amenorrhea. And so unless they're getting intolerable side effects, to push on with it and see what it does.
And so is it possible to use 2 different, let's say if you're on like Ryaco, like an agonist, like you're going antidepressant agonist, but then also the Mirena. Is that possible because there's 2 different pathways that they're working at different, or you wouldn't normally you do one at a time?
So that's a really good and topical question. I would say like 2 parts to that, my answer. One, yeah, definitely I would often use a Mirena and a pill. So if we're getting good reduction in bleeding, or someone's not bleeding but they're still getting ovulation pain, then adding a pill on top. Or if we just can't quite get to no bleeding with either a pill on its own or Mirena on its own, then adding 2 together. Ryaco's different and it's new, and there's not a great amount of evidence about what to do. Like, I certainly wouldn't add a pill to Ryaco. I don't think there's a reason that you can't use a Mirena with Ryaco. You probably don't need to. But if someone has a Mirena and then you think, we're not quite there, and Ryaco is the thing that you want to try, I wouldn't take it out. I would leave it, see how the Ryaco goes, and then think about what to do with it. Yeah.
Okay.
Can I just comment?
Yes.
I'm not a professional. I'm a stage 4 endometriosis. I've had that for a long time, and I've just been put on the pill that you just talked about.
The Ryaco.
Octulets.
Yep.
And I've been on that for 1.5 months now, and it's really good. It's really good because I was on the Mirena for around 3 years, couple of years back. But it just had lots of smooth swings, and it didn't go that well with me.
Yeah.
But the pain is not there, but everything else was there.
Yeah.
With this, it's too early to say, but it's just the pelvic pain has just gone.
Yeah. Awesome.
But I don't know. Yeah, I don't know how far it's going to be. So I don't, even think about it. But at the moment, it's good. Yeah,
That's great. Yeah, it's such a good addition to, and particularly that it's on the PBS. Because when it first came out, it was like $160 a month or something. My only criticism of that is that they only put it up for people with proven endometriosis. So if you haven't had laparoscopy or you don't have endo, you don't get that discount. And it's like it works really well. Endo and no endo is my experience so far. It's pretty new. And I think it's better than like using Zoladex, which was an injection that we used to use. And it's got the estrogen and progesterone in it, so you then don't have to worry about bad back. And it's very handy new addition.
So is it just because there's more established evidence around like the pill as a first line that you would go towards prescribing that than the newer
Rayco.
that Rayco? Yeah.
No, I guess just Rayco's kind of next level
Yeah.
suppression. So I would never start with
Yeah.
that. I'd always try. And like even with Rayco, you know, I've had a lot of people that I've had on Zoladex for a long time. And after 6 months, you always have to give ad back, or then there are risk of osteoporosis and, you know, complications of being in an early menopause status. But yeah, Rayco is a little bit nicer. But even Rayco, I would always be working towards getting them off the antagonist or antagonist and back to something like a pill, just so they can have a little bit more of their own, hormones cycling around. Yeah.
Very interesting. Thank you.
Question.
Yeah.
What about with an adolescent? If you've got an adolescent, at what point, you know, that question of, you know, they're desperate for a lap or they don't want to be on the pill, that kind of, I think that the girls that come through that really don't want to be on, have anything, you know, artificial in their body. What is your thoughts on that? Well, I would say that surgery is artificial things. Yeah. And it's very invasive. Look, I usually talk to people about not starting with a laparoscopy, starting with hormonal management, because there's a possibility that you never need to have surgery. And for some people, that's good. That's exactly what they want. And for other people, no. And there are different reasons for that. With an adolescent, I'm so reluctant, and all my colleagues are the same. We are very, very reluctant to do laparoscopies on teenagers, because we know that the younger you are, the more laparoscopies you will have. And like that in itself says they're not great outcomes that you're having repeat surgeries. So I would really talk to them about the reasons why we're recommending hormonal management over surgery. And if they were really, like if we tried non-hormonal things, so if we were trying things to reduce flow, if we were trying different analgesic medications and we were still not getting adequate relief and they're still really not keen on surgery, then I'd talk about sending them to an adolescent gynecologist before I do the laparoscopy.
Any other final questions? Discussion? So Kitty and Richter, who's the company that does Rayco, we've got a meeting with them over the next couple of weeks to try and get them to fund access to Matilda for rural and regional group.
Yeah, I understand. Because like say you're young people who are hesitant for the pill, well, there's just so much misinformation around the harms of the pill, but like having social media advice that's evidence-based from professionals is just such a good counter to that misinformation. So yeah, it's great.
Yeah, that's what you're
hard. It's fun to
It's why you have to be on TikTok now.
yeah, you can be on TikTok. Yeah, we have to
They actually say more people get their information from TikTok than Google. And I heard a stat the other day that nutritional information on TikTok, someone did a study, and less than 2% of it was accurate.
Yeah.
It's so scary.
It's the diagnostic rate of ADHD that people come in and be like, and learn about it. Yeah, I'm on TikTok. And that's why I think I've got it, yeah. But I do think like I mean, we get referrals from Instagram to Matilda quite a lot, but I would say anecdotally in clinic, lots of the adolescents I see have done with being because of that whole my brain, and I don't want to put anything in it that's not natural. I actually find, because I do see that a lot, and people in their 20s a lot as well, less so in the sort of generation above. Yeah. But that explanation about having a period every month from 13, that actually really resonates. Yeah. Yes. And they go, oh yeah, right, that does make sense. Okay, that makes sense. Yeah. Sonia Grover has written a thing on the NOI group, who, if you know about them, from South Australia, who do a lot of pain stuff, and she's written a thing about periods on that that talks about this physiological process that happens, and Sonia's pretty brutal.
Yeah.
So she resonates. So yeah, it's probably the way she's now doesn't go well, but it's kind of a funny now, really. Yeah. But she has this thing where she does like a potato peel and everything. Yeah. But it does make you go, okay, that's pretty intense.
Yeah.
Yeah. And Joe, the other thing I wanted to say about doing this in adolescence is, like, even though we do these all the time, and most of the time they go okay, they go fine, like, it's an invasive procedure that carries like a real risk of serious complications. Like, people can die from the laparoscopy if they get a vascular injury, people can get a bowel injury and end up with stoma. And if you're 15 and you have the stoma, like, it's a really, and that's very rare. You really have to think about that and whether it's worth taking that risk.
Yeah, I think that concept of, that back-to-back flights, you don't want to be starting young.
Yeah.
Which I think, not the same.
And is that sad because the surgery it's a form of trauma in a way, and so that brings on more.
It's why it's about laparoscopies.
Yeah, the earlier you have a laparoscopy, the more likely you are to need more. Is that just because of the inflammation, like the disease being?
I don't think so, because like, if you look at people who've had multiple laparoscopies and you look at the findings in the histopathology, a lot of the time, they've had endometriosis the first time, and then, maybe there's a couple of years out of another lab and there'll be a bit of endo, but then you look at subsequent ones and there's no endometriosis. So it's probably more of a sensitization process that's going on. And then you put them to sleep and you put holes in them and you burn things and cut things and you feed into that sensitization level.
Mm-hmm.
And I think for a long time our thinking was surgery is the best way to treat it. But we're evolving a bit more now to say, certainly doing repeated laparoscopies doesn't seem to have the same benefit as we used to think it did. And we have to be really mindful about that.
And that probably the education piece around that pain as a result, not a result of the endo growing back, is treatable as well. It's modifiable is probably the really important bit. I think one of the things that I learned with one of the group calls that we had on Matilda a few weeks ago was from our community lead, and she talks about she's had 3 surgeries, and she was talking about, well, with someone who didn't have a diagnosis of endometriosis, and sort of sharing, hey, there's actually still so much that you can do. And initially she saw Joe as a pelvic health physio, and she was like, why am I getting sent to a pelvic health physio? What's the point of this? Got heaps of relief from it. Then she got sent to, she sort of seeing a psychologist for anxiety, seeing a dietitian, all this sort of stuff. And I asked her, I was like, so what helped more to help manage your symptoms? She was like, yeah, all those other things, like the actual surgery wasn't that useful for helping with my symptoms.
Yeah.
So that's quite interesting things we need to consider. And I think it's like, what are the controllable factors here? What is modifiable, and it's not easy. It's much easier to just go under the knife and get an operation from a patient perspective. And it's much harder to change those lifestyle factors, which is why we're so passionate about supporting around surgery with those lifestyle factors, because it is a time that they have high motivation for lifestyle change. So we're kind of using that in a way to our advantage to hopefully get a better outcome for that surgery. And there's like a bit of a shift towards this one and done approach of not doing it early and trying to make sure that it's a good job when they do it and they're supported from a multidisciplinary perspective. Sorry.
No, that's very fascinating. Yeah, I mean, I've definitely seen people who've had, we have this one woman that just stands out in my memory for some reason. She was in her late 40s. She'd had, I think, 13 surgeries, including a hysterectomy, and then more laparoscopies after the hysterectomy. And I met her, and I was the first person to ever examine her pelvic floor, which was like overactive to the nth degree, and sent her to a pelvic floor physio, and she got great relief from that. But this woman had 20, 25 years of pain that if we'd addressed it earlier, have saved her a whole lot of surgery and a whole lot of years of pain potentially. So I'd love that that's in there. Look for these things, treat these things early. Yeah.
Thank you, Lauren. We've got access for Lauren, all the patients that go through, not all of them, 10 of them, as part of this grant, to get access to Matilda for anyone that's getting laps done here in Brew. So, let your patients know and see that up with you guys.
Thanks, Lauren.
So this next part is the experiment. I think. Yes. We're on an experiment. So I don't know how many of you know each other. That's what I was sort of trying to feel out before. But one of the goals that I think, and showing to someone before, was actually enhancing like cross collaboration, multidisciplinary collaboration and awareness of the various clinicians that are here locally in Broome and surrounds. We don't have to do this, but we're going to try it for at least one time. So I want you to turn to the person next to you, or if you know the person next to you really well, then move and which is probably the case. Seeing as everyone sits down next to people they know. Introduce yourself, share your biggest gripe or the myth that you keep having to educate your patients about, and then share your biggest strength as a clinician. So like what sort of people should people sample to? So I want to set a bit of a timer for like a couple of minutes because we've got more great people.
Everything. Yeah. Just like that.
Awesome.
Yes. We decided to get a snack point and using it just so it's. Clinical service.
And to re-explain gently
I'm getting it.
So yes.
We've got a few more of them coming up after the upstairs. Make sure that you get around the room. I feel like I should have told people to bring business cards and stuff, but hopefully you can write down and refer.
You also have business cards that exist? No. In a public system, that probably don't exist.
Pro hospital. I'd like to introduce our next speaker, which is Jo, all the way from Perth.
I'm going to talk similar to Lauren about 3 clinical perils that I wish everyone knew as about pelvic physio. So, number 1, education on a pain system is foundational. So, I think I only treat pelvic pain, some or endometriosis, a bit of both, but not really much beyond that. And I think as Lauren said, lots of these people have had pain for a long time. So I'll rarely get someone come in and say, for last month my period really hurt, but before that it's fine, don't worry about it. So I think often these people are coming in and they might be 25 or 26 and they say, well, I got my period when I was 10 and it really hurt. And that was really hard, but I kind of just felt with it. And this, when you think about it, that's 15 years of, that being problematic. And so I think even if we think, they think it is, related to endometriosis, I think being able to really educate on a whole system level is foundational for them getting better. So at the practice I work at, something we've really introduced that's really worked well for us is that we capture the central sensitization inventory as they come into clinic. So before they come to see one of our physios, they have to do a very long, which is a bit sad sometimes, collection of questionnaires. But they get to do that at home, so they can sit down and kind of fill it out at home before they come in. But in that, it's the central sensitization inventory, the pain catastrophizing, and the pain self-efficacy. And I think what that has enabled for us as a clinic or as clinicians is that it allows us to make their story a bit more meaningful to them. So, if they come in, they've scored above 40 on the central sensitization as clinically relevant, we can kind of say, hey, we've got a really great objective measure that tells us that your system is upregulated or that we need to work on that. And if we don't work on that and we just, treat the pelvic floor, we just treat this one part of your body, that you actually probably won't get out, that we need to adjust your whole system and what feeds into that system. And it's the same, I think, with pain catastrophizing. So I think the hill I'll die on is probably that we need to address people's fear around pain and their ability to have hope for change. So I think the pain catastrophizing is, how scared are you of your pain? And I think that resonates so strongly. I treat a lot of adolescents, but they're so scared of what that means. What if I have a flare and it's swimming day? Or what if I've got a flare and I've got a birthday party? So they constantly live in that fear of, what if this happens to me at this given time? It's so unpredictable. And so I think that piece of education, and I'm going to talk about ways to educate, but I think having that pain catastrophizing, that there's good evidence to say if we don't address fear and fear of pain, that in 1 year's time they won't be there. And so I think really understanding that at a foundational level, and sometimes in my first appointment, I won't touch the patient. I will solely talk to them for a long, long time. So often about 30 to 45 minutes of us chatting, and then I might educate them. And we might not do anything physical for the first, it might not even be the second appointment. So I often will set that expectation when I start as well, so that they're not, I think when it comes to the physio part for mine to be, where you're going to touch and push on me. The next thing is I say make it meaningful for them. So this is something that's grown for me probably over, I've been a pelvic health physio now since, maybe a long time, maybe 7 or 8 years. And I really have mainly treated pelvic pain. So over that time, I've learned some things that really work. But I think it comes down to that we need to make it meaningful for them. So their story in a way that they understand at a level of language they can relate to and something they can take home. So social media petrifies me, but I will say that we often talk about pain, and for those that are younger, I will refer to social media accounts now from educated clinicians. So where I can say, look, you're gonna look at social media, you're gonna be on TikTok or Instagram. Let me write you a list of clinicians that you can look at and follow, so that you can take some things when you're doom scrolling, nice on your phone, please can these be featured on your newsfeed, so that at least you've got something. And I think at first I was like, I'm not sure if I can do this, but it has worked. I think for the adolescents, you know, that Millie Martin is an incredible pelvic pain researcher. She's a PhD on education. She talks about it in meaningful ways. I think there's great clinicians. We talked to Sophie Callan's one of the psychologists on Matilda. She also does a really great job with explaining pain. So I think having those people takes a little time to find them, but once you get them, being able to say these are you should follow so that it's educational. And I also draw a lot in clinic. I have a drawing that I do for every patient for them to take home, and it's very basic. So definitely not an artist, but it's essentially their pelvic organs, which are often just circles next to each other, and as they relate to their anterior wall of their spinal cord, up to what is a logical brain next to an emotional brain. So it's that loop, and I explain a lot about how what they've told me that, you know, I was 13 when I got my period, and that's when my pelvis first kind of felt like it was on fire, and how that message goes up to the logical brain. The logical brain tells us that's pain because it's the experience we felt, and then it's very appropriate that we feel anxious about pain. That's how we protect ourselves and protect our body out in the wild. So we respond by, you know, protecting ourselves, and that's how pain would have done it as well. But then if that happens every month, what do you see? You see a system that gets very good at what should be a back road becomes a free one. So very, very efficient, with lots of staff that live in the logical brain that are saying, oh, the pelvis is not getting it. Yeah, up we go. And then the emotional brain has lots of feelings about it. So I'm happy to circulate that drawing. Every single one of my patients gets it. And I think it's something they take home where they look at and they say, that's actually my story. This is how I got here. And then I draw all the ways I'm going to change it on there as well. Almost just about. So Lauren talked about. So I remember a very, very, very experienced physio saying to me in my first year of my master's, you do nothing at all in consult. You must fix the bowels. You must always address the bowels because bowels rule the world. And if the patient leaves, they've still got a bowel problem, it's never going to get better. So, and it sticks with me. And I think Lauren talked about constipation, and normal bowel movements are 3 times a day, it's 3 times a week. That is the norm as set by BAL Australia, and it allows for a lot of variability. It allows for those guys that go regular 3 times a day to those that go 3 times a week. So it really does have that spectrum, but it is not normal. I put the Bristol stool chart on here. It is not normal to go type 1. Normal is 3 to 4. It's not normal to sit there for ages. You shouldn't be on your phone sitting there for ages. You shouldn't be wiping 50,000 times, and it shouldn't hurt. And I think changing that narrative of, you know, I think the patients that come in and say, oh, but I've been constipated as a child, that's just who I am. I'm just constipated. That's not the way it works. That requires a dietitian referral. That requires looking into that. That requires optimizing your habits, what's causing that, how you sit on the toilet. Put a lovely picture up here of how people should sit on the toilet, and educating around the influence. And I talk a lot about cross-sensitization, that, you know, all the organs fit together in this little tiny space. It's not well designed. That we've got a bowel next to a uterus next to a bladder, and I call them nosy neighbours. So if you've got them all there together, and you imagine if your neighbour's house is on fire, you're feeling heat. So if the bowel's house is on fire, we're all feeling heat. But the same thing is that maybe you didn't start with a bowel problem. Maybe you had a uterus problem with the periods, but now you've got a bowel problem. And that could be because they share the same environment, they share the same neural pathways, you know. They're nosy neighbours, they're all in each other's business. So if you fix the bowel, do you then make the periods better? Probably. If you fix the period, do you then hopefully make the bowels better? Probably. And the same thing happens with the bladder. So if you I would put my money on it, if you fix the bowel, the bladder will be better, because no one weighs well when they've got a full bowel or they're constipated. So that's my take on fixing bowels are very tricky to fix. I say, like, you know, with some love, because they can be tricky, particularly those that are notorious for being a bit sluggish. My last one is treat muscles, but don't forget what drives the change in muscles. So we're not born with tight pelvic floor muscles. So something has caused that for people that come in with tension. So I think about majority of people with pelvic pain or endometriosis will have tight and tense pelvic floor muscles because they will be guarded. So, you know, it's not, I think about, you know, as in childhood, they're not tight, not 68 pelvic floor when they're 7 years old. So we're not having problems at that age unless you've got a true pediatric continence issue. We're not really having problems at that age. So something has changed, and I think that's a really important education piece to say to the patient, hey, there was a time in your life where these were tight, and that's, that means we can change back. It doesn't mean it's permanent. But something's caused that. So is it that, you're 14, you went to the bathroom, you were given this tampon, you went to the bathroom, you tried to put it in, you thought, oh my God, there's no way that goes in there. Doesn't fit, doesn't go. And that might be that first kind of feeling of like, oh, that's like, it doesn't go. Okay. So I think, and that can sometimes start, or maybe is that painful period, you just want to kind of go like this, because that's really uncomfortable. So often it's either consistent pain, they might be having poor sleep, mental well-being, movement, stress, beliefs, fear. All of that contributes to how our muscles function. That's across the board. I think we can all, not that I'm very good at treating nets, but I think, when those contribute to it, that will cause some tension of how we want to protect our nervous system, protect our body. And the analogy I often use is, if a bird hurts its wing or it's been really sore for a long time, we'll often hold it really close and protect it, and this will often get really tight. But that bird will recover, and it can use its wing again, it can relax those muscles. And I think that resonates quite well with people, that I think where I try to educate that, there's no point in me pushing and prodding your muscles for a session. If you walk out here and you're still going to go home and sleep poorly, you're going to be scared. You're going to be stressed about your job, and you have no idea how the pain system works, because you'll end up being a patient that comes back to me every 2 weeks to have their pelvic floor release, and that's not a good outcome. So, do I get to ask questions now before you?
Yes.
Does anyone have any questions about that, or any of that, or anything else about pelvic physio?
I'm happy to kick us off, because I think this is a question or an assumption. I think you, as a pelvic physio, you know what happens in the room, or what happens in the physio room, but that can be quite a shock for people.
Yes. So what happens at pelvic floor physio appointment? So I think that is a shock for people. We now have a video that goes out after the first appointment of like what to expect when you come to pelvic floor physio, because I think Anna, our community lead, talks about that, and she says, "Wow, that's Joe," and then was shocked. So we often, as we collect questions before, we then have a 60-minute appointment when we can ask questions about everything from their whole life experiences to their bladder function, their bowel function, their sexual health function, their general pain, things like that. And then if normally pelvic health physio, so some of us have done a master's degree, some have done APA or physio courses on how to become one, but we're trying to do internal vaginal exams. So the option is that we can do an internal vaginal exam to map the pelvic floor muscles. So that is to assess, how well do these muscles contract, relax? Is there any pain when I push on those muscles? Does that replicate the pain that you experience? What happens when you do a little sit-up or a cough? And what the tissue's like and things like that. So that can be one part of it. Some patients will never have a vaginal exam. Some patients are probably doing less than maybe used to, I think. So they're probably lowering, I think, less invasive as time goes on. And definitely not with adolescents. But I think, one part of it is the vaginal exam, and then the external exam. So things like their glutes, like how they're moving their body, a bit more traditional, I suppose, physio assessments.
So for men, so don't treat that many men, but there is pelvic physios that work with men.
Yeah, it's a pelvic physio. So if you're a male, you can have a rectal exam. I don't really treat men anymore, but I used to. But they often have rectal exams. So it's the same thing, pelvic pain. So pelvic pain in a man is really under-recognised, under-discussed. It's really actually quite awful how under-discussed it is, because it's very prevalent. So you can have a rectal exam for that, or things like your prostate and rectal continence, things like that. One eye-opening experience.
I just remember I've had a bunch of patients that have not with any of Joe's clinic or the crew there, but they've had very interesting experiences going to a pelvic health physio and being quite shocked. So I think if you're going to refer to a pelvic health physio, maybe give the heads up to say, hey, pelvic health physio, they sometimes do an internal exam And then they might be like, what does that mean? And so sometimes just telling it in plain English is helpful to give them a heads up.
Yeah. And so it's really, I think, pelvic physio has, it's part of our masters to really do heaps of care, like trauma-informed care, and making sure that's really done in a way that's it's very, very slow. And yeah, just lots of discussion around it.
I've got one more question, not a second question. One of the common myths in, I suppose, in more of my area of back pain is around having a strong core or tense muscles. And I think in the pelvic health space, that's quite common as well. And to kind of cut to the chase, the core is not that important for back pain as we used to think. And actually, a lot of people with back pain have over-braced or tense cores. And a big part of their treatment is learning, teaching them how to relax and actually feel confident and safe in their body. And there's a similarity in like the pelvic floor as well. We used to have all these Kegel exercises to like tense. So I wonder if you can comment on that, please, Jo.
Yeah, I get that question a lot. I think definitely there's probably women that are maybe in their mid to 20s or up. I think the adolescents have no idea what pelvic floor is, which is kind of nice and but they become very ignorant. But I think, yeah, this concept of, they'll often come in and say, I've got so much pain, I must have a really weak pelvic floor, because that's what, social media told me that there's lots of trends on social media about pelvic floor. But what I would say is I always educate on muscles are meant to, contract and relax. They're meant to move through full range of movement. And so this obsession with having one that's only good at contracting doesn't really fit that mold. And so I think we used to also then kind of obsess about relaxation, but now I would say we've really changed that full range. So full range of movement, a muscle that can bounce up but also relax down. And that strength, I'll often, patients that haven't had babies that have pelvic pain and endometriosis, I'll say, just assume your pelvic floor is probably strong. It's probably on, because if you're having all these symptoms, we don't really need to uptrain. We're not having symptoms of problems of like that. We just need to get it moving. The goal should just be movement. And I think that probably crosses over to things like Pilates as well. That's one of the questions I get a lot is, at Pilates, my Pilates instructor says, tighten your pelvic floor before this exercise. And if they've got no reason that indicates a weak pelvic floor. So I think even in Continence, I'd be kind of thinking on that over time, that's why they're leaving. But without assessing them, I would say don't contract. Like, just let your muscle do it. It will do its job. It's probably already on. So just assume that it's already on. Try focus more on, can you move that muscle direction?
That's my problem. I think we've got the 5-minute mingle.
Another 5-minute mingle. So is everyone? Maybe we'll just skip this one. We'll do the next one. We'll move on to Emily. So Emily's a dietitian in Perth. She's a PhD in cancer of endometriosis, and she's recorded her 3 clinical pearls as well. So I'll just see. Emily is one of the accounts I actually recommend that patients follow, because she is very evidence based about what does and doesn't, and get good evidence behind it.
Bowels run the world, hey?
Bounce around the world. All right, we're on to you can feel these, a 5-minute mingle. We skipped the last one. Yeah.
There's still heaps of food, so we could do a bingle, get some food, learn about someone that you haven't met before,
I think
and then we can come back. We may make that the last 5-minute mingle, just in the interest of time. And buzz out here on Friday night. Unless we can have more if you want to. Co-design how the education looks. But, we can food and sit down next to someone that you don't already know, if you're not met everyone already. Otherwise, we'll just share the same things that we talked about last time. And I'm going to be back in here by sort of just after 1:30. Nice. Sorry to the nice conversation that I was overhearing here. That might be worth sharing in terms of ultrasound being part of the diagnostic
now. So ultrasound is now being approved as a diagnostic. It can be diagnostic. So versus in the past, we had a laparoscopic surgery for diagnosis, and I think we chatted to Lauren about this last night. That drive of people wanting a laparoscopic surgery was a validation piece of diagnosis, and I think particularly in that, I see that a lot in my adolescent patients. They're like, "I just want the lap, But I think it's shifting now. We shift away from that to think of it as, it's not it is diagnostic, but it also ultrasound can also be diagnostic. It's done by a really good ultrasonographer.
And it has to be transvaginal.
Has to be transvaginal, and so that's also a factor with adolescents. Is at what age can they have a transvaginal? That's a narrative I think that's just often discussed with the patient. And I think also, I would say, like in Perth, we have maybe 4 clinics that are really good sonographers they refer to. But I even think if you ask any gynecologist in Perth, they'll have their ultrasonographer. They want you to see it's that one person and their expensive scans. And they also talk about, at what point in the cycle. It's so many variable pieces that can be part of that narrative too.
Not as expensive as surgery, sure.
Expensive surgery.
I think that piece of validation, just to touch on an important point there, it doesn't mean that people that don't have endometriosis, we can't validate them as well. They still have pelvic pain, and that's something that Lauren touched on before, and it's something that we've put into the Matilda program, which we'll talk about a little bit later on, just for context, to make sure that there's a pathway, that we know that between 10, some research up to 80% of people having a lap don't have endometriosis, that they still have an experience that is validating for their pain, and they still have knowledge and are still empowered with tools to help them manage their symptoms and their conditions of pelvic pain, which is not endometriosis.
I heard a really, we were at the Ages conference last week, which is the Advanced Scope Gynae conference last week, and I had a really, really amazing statement from a gynecologist who said, you know, what I like to say before surgery is, like, it's actually a really good outcome if we do surgery and you don't have endometriosis, because then you don't have an incurable, painful, lifelong condition. Yeah, so that, I think that narrative of, you know, it's actually can be, it's okay. Like, this is actually like how in other people, I always think about orthopedics sometimes if they do like a surgery, they say, oh, actually, it's going to show me how bad orthopedics. But if they say, no, actually, you didn't, you know, tear your hip labor, and that's actually not the problem or something like that. And it's not, there's no validation piece there. Versus, I think in endometriosis and pelvic pain, there's such a chase of validation with surgery. And if we can shift away from that and actually say, okay, this is kind of, you're all coming down to this road together. You're going to have surgery and you're going to have a bit of a branch apart, but you're coming back. The treatment comes back the same in pelvic pain and endometriosis. You know, we still talk about the same things. You often see the same practitioners. So I think thinking of it more like it's a journey with a small split. Yes.
Just first of all, thank you for coming up to Broome, because a lot of us with endo, we feel very left behind in a regional town that doesn't really talk about this. So thank you. I also have endo, over 20 years of endo. It's been like a lifelong thing for me. I would love to know your thoughts on deep infiltrated ultrasounds, as I have been flown from here to Perth to have them a scan that didn't show you anything, came back up, and after 20 years you kind of get to know your body and kind of the symptoms of when endo returns. I've had 3 surgeries. I was riddled with it when I went in to have my laparoscopy. I had to fight to have the surgery. But yeah, the deep infiltrated ultrasound showed absolutely not 1 ounce of endo, and when they went in, I was absolutely riddled, and it moved to organs as well. So that I find that really interesting, because there's a lot of like research on the deep infiltrated scans and how good they are, but in my case, it's so great.
That's out of my wheelhouse. Also, it's a smidge of my wheelhouse, but not as a physio. Maybe more as from Matilda. But I would say that what we know about that is, did it involve bowel prep as part of your scan? Did you have any bowel prep?
No, so I didn't. That was just a routine find within the laparoscopy after the scan.
So I think like there is a movement about, you know, how we do scans, and it's for some patients, if they suspect it is that stage 3 or 4 endometriosis where it is deep infiltrating, that they'll get you to do bowel prep before, so they've got a clean, I suppose, bowel like they would for a colonoscopy, so that they can get a better image. So there is some the way I'm seeing more patients do bowel prep, which I think does hopefully at least give a bit of a better image. The other expression would be is we had it done, which I wish it wasn't. Acting ends, yeah. So I mean, you would hope that was really good. Like that. And I would hope that was really good as a scan, but I also think it can be where you are in your cycle at that given time as well. And I would also say they're not perfect ultrasounds. They're not. Like, I still think they are diagnostic, but what they will say with the diagnostic is that it can rule it in, but it can't rule it out. So, which is the tricky thing, is that if you have a clean ultrasound, that doesn't mean you don't have it. That just,
If you had a clean ultrasound, we would treat it exactly the same way, because you still have pain. So we still have to treat it.
100%.
So then we can repeat the ultrasound, which is far better than having to repeat surgery.
And I also think like a lot of patients will pay for private scans in Perth. We do see a lot of that there'll be specific gynecologists that want you to go to a specific ultrasonographer because they've done a lot more advanced training in it. So I do think there is that. I've read a few in Adelaide. There's a really big group in Adelaide that is doing a study called Imagendo about ultrasound and using AI to make it more definitive about what they can see, like so that they take away a bit of human error in the scan. And I also think MRI, there's moving a bit towards MRI for deep infiltrating endo, is that sometimes if they're looking for a surgery, and one of the big themes of last week was having the right team in the room at the right time. So if you're a surgeon and you suspect there's other organ involvement, don't get halfway to the surgery and then call the colorectal. Like start the surgery with the colorectal surgeon, start the surgery with the urologist, and that relies on efficient scans because you need to know beforehand. So I think that we are seeing probably more patients also having an MRI if there is suspicion of deep infiltrating endometriosis.
Interesting, because I think once I'd had that scan and nothing showed, then it was kind of like, well, you haven't got anything, so there's no reason
Feel quite disheartening.
to
Yeah.
So then it was kind of like cycling back to the start and having to fight for my symptoms and everything I was kind of experiencing. So it's found that quite good.
It's quite validating. Yeah. And I think that concept of a clean, I think going back to that clean scan does not mean there's no endo. Particularly if you've been previously surgically diagnosed. I think it is coming back to that. How was the scan done? Was it, I mean, that was a big theme last week was, who did the scan? How was it done?
I think, so my background, as I mentioned, is more back pain literature. And the more I learn about endo, the more I'm like, this is where back pain was 20 or 30 years ago. There's a couple of studies that come to mind. One was where they had a lady with back and leg pain and they sent her to 10 different MRI centres in the States. And there was not a single there was not a single finding that was common on all 10 MRI reports.
Yeah.
So massive diagnostic variability. That's on the part of the MRI, the radiologist doing the reporting of the MRI.
Yeah.
The other thing that we know that with back pain, 50% of people are going to have a disc bulge with no symptoms. So you have a lot of these false negatives, false positives, where people have findings but they don't have any pain. And conversely, you can have heaps of pain and have no findings as well. And that kind of speaks to the complexity of pain. We know that, something that Lauren talked about as well, we know that the stage of endometriosis doesn't correlate to the symptoms. So you can have some people that have got massive pelvic pain, all the symptoms, you go in and they've got what the surgeons call a pristine pelvis. How do you explain that? That person's still got real pain. And conversely, people that can struggle for fertility, they get investigated and they've got stage 4 endometriosis, obliterated pouch of Douglas, all these sort of like really kind of scary sort of sounding terms, which I think drive more fear and sensitization in that person's nervous system, which we know ramps up the pain system. I think it's kind of vicious cycle as well. So I think the false negative rate or false positive rate, I suppose, the variability of the clinician, and then also things change. Like even in back pain, disc bulges, the vast majority just resolve by themselves. And then in endometriosis, obviously, you've got, like we mentioned, at what stage of your cycle you're on. So there's a lot of variability, and I think it's really easy that leads to invalidation for the patients. What you've described, and you've got to advocate for yourself to keep going down that treadmill. And I think the common theme is still that the treatments are quite similar, actually, and hopefully, there's still avenues that you can go down to help get on top of your symptoms.
Yeah, and I think you wouldn't see stage 1 endometriosis on an ultrasound or stage 2 even. All right, Alison Brown, actually I might introduce. She's senior clinical psychologist, adjunct senior lecturer at UWA's medical school with over 20 years of experience in rehabilitation and surgical settings across Australia. She has established psychological services in major hospitals, led national multidisciplinary research projects, and continues to provide clinical training and supervision to health practitioners. It's a mouthful.
Highly qualified.
Yeah.
I think it's quite a large file, so might just have to roll with it, or I can send the video out for another time. Yeah, because it's kind of stopped completely.
Right. We'll we'll skip this. We'll jump to mine. So up you come. I'll let you introduce yourself to everyone.
Good morning, then we've got a little bit of a lived experience interview, but I recognise it's 7 o'clock, so
I'll be super quick.
feel free to go. We won't be offended.
Okay. So I've met some of you before, but my name is Vanessa Ellis and I'm a yoga therapist. And what that is basically I take the tools from yoga practices and use them in a therapeutic setting. And all the stuff that I use has clinical evidence behind it. I have a science background, so I quite enjoy reading research papers, but I do read research papers. And the idea in terms of, when I do work with clients one-on-one, it's writing an individual program for them that maybe does focus on some movement, postures and things like that, but also looks at mindfulness practices, maybe breathing techniques, and it looks at addressing the person as a whole. So not just the physical, what's going on physically or what they want to maybe look at physically, but also emotionally, mental. And we also take in that, it's that whole like biosocial kind of model. And that can cover things from, chronic pain, if people are, stress management, anxiety, poor sleep, that kind of thing. All right, I have to check this one here. And I press next on this one.
Yeah, it's a bit confusing. There's a little arrow to.
I've only got one slide, so there we go. Beautiful. Okay, so what I want to talk to you about today is, I guess here you're looking for evidence-based, I suppose, interventions that can enhance your patients' outcomes, and yoga therapy can do that. So in terms of looking at integrating yoga into a multidisciplinary care. So 3 points that I wanted to talk about today is basically transdiagnostic. So what that means is if someone comes to present with endometriosis or with pelvic pain, the, I guess, postures, the breathing techniques, things that we would recommend and that we would use, it's not just for that. It can go across. So if they're also presenting with anxiety, they've also got maybe sleep issues, pain, those kind of things. It's kind of these practices can assist through all of that. And I think that's a really beautiful thing in terms of that it's, it's something that they can take with them. So, for example, if they wake up in the middle of the night with pain, they can utilise a breathing technique, or maybe they get up and they do a little moving technique or a posture that they stay in. Perhaps maybe before they're meeting a clinician and they have anxiety about what, maybe they're discussed in that, or maybe, what that procedure might be, they can again use those techniques to, regulate their nervous system, which, as Joe talked about, that stress and pain cycle can kind of just be released a little bit. The second point I wanted to talk about is that it's accessible. Basically, you don't need any fancy equipment, outfits, anything like that. It can be modified. People have physical limitations. So basically, it can be done anywhere, anytime, and that's a beautiful thing in terms of, if they need it in the middle of the night, they can get up and they can utilise these practices. So it's very accessible. And then the final point I wanted to say was that it's acceptable. So yoga is definitely more now in mainstream. It's not kind of seen so much as this, kind of practice that was done, somewhere else. And I think that then if someone is doing like a yoga practice, it can be, it's accepted that they can use that movement practice as part of their treatment, but also they're continuing through their daily lives. So, so that's my 3 points. I guess what I really love about the yoga is that it also gives that client, patient, those self-empowerment, they have control over their own, their own body, their own emotions, their mental state, and they can utilise these tools when they see fit. So if I've got 1 minute, we'll quickly I might just do a movement activity rather than the breathing one, because I don't want everyone to go to sleep for the last little bit. So I'm imagining that you will be either working on computers or doing anything. So I'm going to invite you just to bring your arms out in front, and so you can see your forearms. Yeah, and then just make little fists. Don't have to be huge fists, but just tight, not too tight. And then we're just going to do some little wrist circles. So you're just going to drop the wrists down. And what I want you to try and think about is keeping those forearms up, because, they want to do this, but I want you to see, there might be some pops and crackles. That's okay. And then go in the opposite direction. Okay, and then very quickly we'll open the hands, and then we'll just open and close through the elbows, because everyone forgets about the elbows until they knock them on the corner or something. And then we all remember where our elbows are. And then pick the hands on the shoulders, take the elbows out to the side, maybe some little circles. You might have to all move a little bit so you've got a bit of space. And you can make these circles big or little. Again, whatever seems kind of feels good. Go with it. Then go in the opposite direction. back. And then keep the elbows out to the side, and then you can gently draw the elbows towards each other and then back out. And if you want to kind of bring the elbows back behind you a little bit, like you feel those shoulder blades come together, you can, and then bring it back. Just gently backwards and forwards a little bit. And this is not necessarily, for pelvic pain, obviously, but I kind of figured this might work for all of you. Okay, and then gently drop the hands down wherever they feel comfortable. Bring the chin into the chest, and we'll do some of the semicircles. Draw the chin up towards one shoulder, drop it down, bring it across to the other. Back and forth a couple of times. And then if it feels okay on your neck and you kind of want to make that full circle, you can bring the head all the way up and around. And then when it comes back to center, then kind of reverse. But only if it kind of feels like, yeah, this is where I want to go tonight. Maybe I just want to stay in a little semi-nod, and that's okay too. So make sure you go in both directions, whichever way, whether you're doing little semicircles or you're doing that full kind of circle around. And come back to the center, and then gently lift your. And then that's it. I was going to be quick. That was good. That felt hard. Yeah, that felt really good. All right, lovely. So I'll pass you over to Continence.
Thanks, Mum.
Thanks so much. Thank you.
I might take a little bit of introducing our next speaker. We always love to bring people with a lived experience into the conversation, and it's great that we have 3 people with a lived experience, which is awesome. I hope you found out about the community event we had last night as well. Good, glad to hear. There's recording if you can't get there, but we've kindly got Bridget here as well. So Bridget was brave enough to share her story last night. It's in front of a much bigger audience, but not health professionals. And she's back again with us. So Joe's going to ask her a couple of questions. So thank you so much for giving up 2 nights of your week. Yeah, I think the voice of a person with lived experience is so important in tying this all together. That's what we're clinicians for at the end of the day.
Hi, Bridget. Let me get to this again. So I'm going to start by asking you if you would happily share your story of how you kind of started noticing some symptoms and then as that went on.
Yeah, perfect. Hey everyone, I'm Bridget. I work as a sexual health nurse over at Community Health. So if you ever want a free STI student, but this story all started about 2 years ago. I started getting a little bit of dysuria. Thought I had UTI, when I got some antibiotics, kind of went away. That came back a few more times, and I was like, oh, weird. Thought maybe it was something urinary, got referred off to a urologist. Did all those fun scans and tests, and that also showed nothing. And then at the same time, I started getting some changes with my bowels. So went and got a colonoscopy and an endoscopy. That also showed nothing. Because we're in Broome, you can't get a GP appointment for weeks. I was like, what could it be? Endo wasn't even on my mind. I'd always assumed endo with, painful periods. Obviously, I've been educated now that that's not the case. I got referred to a gynae, saw the great gynae team up here, and then ended up deciding to go down to Perth and get surgery in April this year. Got a lap and a cystoscopy and a few other fun things when I was under, and they found stage 3, bordering stage 4 endo, which was like all over my bladder and ovaries and bowels. And that kind of draws me to here. I woke up from surgery with my, badge pack in, like hanging my leg, couldn't get out of bed. And I was like, wow, I have endo. Yeah.
I get that waking up is often where people talk about kind of that. It's people talk about the kind of overwhelming feeling of so many things when they wake up about, do they have endo? Do they not have endo? What does this mean? What happens now? So we talked a little bit last night about experiences like feelings before, feelings after, feelings on reflection. Do you mind sharing a little bit about that?
Yeah. I didn't think too much leading up to the surgery, to be honest. I was more worried I was going to die than anything. That obviously was not the case. But I think I didn't know a lot. Looking back, I thought maybe the surgery was going to help my symptoms so much, when in reality that hasn't happened. And I didn't think I had very good expectations, nor do I think I was educated on those expectations very well. That's why this app is great. Yeah.
And we talked a little bit, about regional rural access and things and how that's kind of shaped. Obviously, you flew down to Perth, but how kind of living in Broome, what your experience has been like with that?
Yeah. I was obviously lucky enough to financially be able to fly down to Perth, which I think isn't the case with obviously a lot of people living regionally. And I think Broome, we're pretty special with our dining team up here. I think they're pretty spectacular. But if you look further on at Coles Creek, Kununurra, that's totally not the case. And not just gynae people in Broome, it's so hard to get into any health professional up here, really, as we all know, which I think just makes access so much harder.
Yeah, absolutely. You've been viewing Matilda since your surgery. Yeah. So you've had Matilda after your surgery, but not before. So I know we haven't really talked about Matilda much tonight, but how do you think this would have changed maybe how you felt your journey, particularly living in Broome, I think? And how long before surgery did you fly down for, actually? Like, that was one of my questions.
I flew down the night before. My plane got delayed because of Broome. I was like, I'm not going to make it.
And how quick after did you fly home?
I took 2 weeks off.
Yeah.
Yeah, because I had a big intra bleed. So I was in Perth. I was in the hospital for a little bit. But 2 weeks, yeah.
That's cool. Flying forward.
Work, couldn't get off work.
Yeah. So how do you think maybe using Matilda before might have changed how you felt, things like that?
Yeah, so much. I think Matilda is just such a good honeypot of everything that you would ever think of wanting to know about surgery. I think before I had my surgery, I had a great team down in Perth, but you have your, maybe a half an hour appointment with your surgeon, and then you don't see him for a few months. Then you see him 5 minutes before you go to theatre. It's a bit late to ask any burning questions. So I think just having access to, dietitians, clinics, physios, it's just all in a really accessible format. You're not having to go and multiple Instagrams or TikToks or articles or programs. It's all kind of just in the one spot, and it really guides you through this week 1, week 2, before surgery, after surgery. I think it feels like a friend kind of helping you along the way. Yeah, having someone to talk to.
I want to say we didn't talk to her about this. It's a lovely. I know. I thought you said that really nice. Is there anything else you want to share about your experience? Or I'm a really big believer. I ask lots of people lived experience, or lots of my patients. If you could go back and talk to yourself before surgery, what would you say to them?
What would I say? I would take pictures of my belly button. It just doesn't look the same now.
That's a common thread, me.
Yeah. I think I'm going to just reframe my expectations. I was having such painful intercourse before surgery, and I thought, when I wake up from surgery, I'll just be able to have painless sex. That obviously wasn't the case. Was it any worse after surgery? And I think, you get a diagnosis of endo, and it's not like it opens up a world of treatment options for you. It's really just a diagnosis, which is validating in itself, but it's not oh, great, I can have a pill now and my life will be amazing, like some other diseases. So I think whilst getting a diagnosis is what a lot of people want, it doesn't really solve how you're feeling. You're still having that pain. You're still, it's still impacting your life, your work. You've just now got a few scars and a good little story to tell.
And a name, yeah.
Yeah.
Thanks so much, Bridget.
That's okay.
Thank you. I think it was so we do, I know I'm really pushed for time, so I'm going to whiz through what Matilda is. So essentially, because of this gap in care, our overarching vision is holistic care that is affordable and accessible. So physio, dietitians, psychologists, everyone you would want any person with endometriosis to see that's not the GP or the surgeon. separate to that, delivered in a way that is just easy, really. So on their phone was the biggest request. They want it with them all the time. The reason we are for pre and post surgery is because of the behaviour change point. We used to not be pre and post surgery, but we found it really hard to make change in people's lives. And I think surgery is often a momentous time in someone's journey. It might occur early on, it might not. And so that is often a time we talk about, like, the marathon analogy. You know, we're all really good at being fit when there's a marathon coming out. So I think we're good at looking after, go to sleep early, you know, doing all the things. So that's how we have structured our program. So we offer a program of 4 weeks pre, 4 weeks post, with 12 months access, recognising that people might want to dip in and dip out over that 12-month period. It's an educational platform with 4 pillars, so nutrition, movement, sleep, and mental wellbeing, with content delivered by experts in this field from around Australia, which is quite amazing. We've got clinicians from lots of different states. We offer a community, which is my favourite part of the app because it's very active. It's led by Anna, who's our community lead, so she's had 3 laps and a diagnosis of endometriosis. She's also a teacher, so she runs a very tight community, which is good. But our community is structured in a way that's different to the Facebook groups. It's very much people interact with channels that they resonate with. So whether that be the drop of feeling off channel where they want to have events, but it's not something that comes up in a news feed. So therefore people aren't confronted with I suppose negative thoughts if they don't want to see them. And then it's structured around motivating each other about how they're moving, sleep tips, mental wellbeing, pre and post surgery tips. So things like, how do I wash my belly button before surgery? There's a lot of waking up selfies. I feel it's just been another one go up tonight. A lot of like how I look at hospital selfies, my fit check of my hospital gown. Like, it's lots of that, and there's lots of memes about chronic illnesses, and also rating yourself on 1 to 9 of like the dogs or the cats or the guy off the office. There's a lot of memes on there, which is just, yeah, one of my favourite. I couldn't love that more. And then we do coaching calls. So Kev and I run coaching calls multiple times a week where people can join. It's quite amazing how we had one person who just had surgery yesterday who joined on her holiday in Germany. So she's sitting in Germany and we're having this call. There's people in Victoria, there's people in New Zealand. It's amazing how much people can connect no matter where they are on the common thread of what they're experiencing. So the coaching calls are all centered around motivating for change. So it's things that we're proud of, things that are challenging, and how we're going to set goals for the next week. We're on a scholarship fund. So for those who can't afford it, for every 10 that we sell, we give 1 away. And we also actively chase rich businesses to fund our scholarships. People that make a lot of money, how can we make them pay for other things? So I always say, like, if you've got a patient, oh, I just really can't afford it, just honestly apply for the scholarship. We haven't turned one down yet. So I don't think we will, because we're absolutely suckers. So we're probably going to. We've had 6 go through this year. It's been really amazing. I think financial means should not be a barrier to good care if we can make that work.
The program is only $250, which gives them access for 12 months.
Yeah.
To make it cheaper than the cost of seeing one of the clinicians for an initial appointment.
Yeah. If we are partnering with gynecologists around Australia at the moment to offer at a reduced price as part of their clinical fee. So that is something also that for some people that maybe if you've got patients that are flying down to Perth for surgery, some of them might be in partnering clinics. So they can ask their gynecologist, does your practice offer Matilda as part of their service? We've got a discount code for 10 users, valid for 6 months, so 90% off. It makes it $25, did you say?
Yeah.
Yeah, $25 for the whole program. So regional access is the code.
That's thanks to the government. So like I think I mentioned earlier today, I put in a bit of money. We put in these grants. We found out today we were unsuccessful with another one, which was a sad moment. But we put in these grants and like you don't hear from ages, and then they come or they don't, and you're like, what was that on again? Or, you know, all these sorts of things. And you put a budget together that you think you're trying to predict for another year or 2 years in advance, which was really difficult for a young company. But I wanted to make sure that we had access for regional people on there. So part of that grant that came through was for running these events, and we'll run them in the capital in the southwest as well. And we don't really have a license or like restrictions on what we do with it. So I thought let's just give discounted access.
Yeah.
And I mentioned that obviously Lawrence patients, or the patients that are going through here, we'll sort them out with access to.
So patients having surgery in Brew, we will sort out for a significant discount.
And although it says pre and post surgery, that's just a point in time that we've chosen where people have high motivation. So the reality is that this sort of program would help people regardless of pre post diagnosis, pre and post period, like whenever. It's just a point in time, and the stuff that people learn will still be useful for that. So if you've got patients that pass it on,
And the other thing I would say is I know there's quite a wait list for laps up here. So I think when saying 18 months, people might sit on the wait list. Correct me if I'm wrong on that, but I think the other thing is that we say it's 12-month access, but if you've got someone that booked in for 18 months away, like we will happily, if I got to speak to someone for 18 months every week, that would be like an absolute gift, because I think that person's going to be so well prepared and educated and supported going into surgery. And I think they're the people that really do well for surgery. So, and I think our early outcome measures really that height is high.
Yeah, that's right. On the back of this one as well. Yeah. So there's some early outcomes from there. And maybe, who knows, in a utopian world in the future, they might manage their conditions so well that they actually decide not to have surgery.
Yeah. I mean, the gynecologists might not be happy with that, but with
I
think some of them would be really happy with that. A good gynecologist would be happy with that. So I'm going to share, last bit is just this follow-up outcome survey for the government. So we can tell the government that we can kind of be educated.
There is a feedback section there, so yeah, please put your thoughts in there.
Anyone you want to hear from, anything like that, because I think, if we come back.
What do you think of stuff later on? Then
Next year, after Easter, but before the races.
Yes.
Yes. How many people have you had through from your program?
124, I think, I've last checked.
124.
A third, not all the way through the program. A lot of those are in the pre-ad phase. So there's about 30 to we're closer to 40 gynecologists that have had patients go through that. From Australia, mainly Australia or New Zealand. Australia, and then a couple from the US as well. Sort of targeting Australia first because we can jump on the plane and meet these people. Much easier. Flights to New Zealand as well, of course, was a bit further, but also health
in
jurisdictions are different in this state.
New Zealand is harder to bundle in with surgical care. They have different models than Australia, which is a bit difficult. But on our previous app, before we were doing pre and post-op care, we had 1,000 users or 1,000 downloads. It was over a much longer period of time.
Much more accessible program, I think, in certain ways, because it was just, and this is on the App Store as well, people can download it, but we're sort of targeting more through gynecologists.
Yeah.
Well, can you put it in their like patient flight? They've got a really thorough like rest flight, and they ask for patient feedback on it, and so like it could be a good time to.
We've had a few conversations. The public system has been, to be honest with you, it's so difficult to do.
So difficult.
Yeah.
Lots of red tape, lots of barriers, funding, etc., etc. But I think when patients aren't paying for their surgery, maybe they're more inclined to pay for another program. I don't know.
Because they put a link into the endometriosis website. I mean, sorry, that's what is pelvic pain or
Foundation Australia.
yeah.
If they,
I think they just put a link to your program and then even the discount.
Yeah.
So some of the surgeons will refer for public patients, even that's a bit tricky. Like most of them work across public and private. So they will tell their public patients. But I agree, I think
it's not worth another shot again.
Yeah.
So do you, sorry, just letting clarify that actually. So do you need to have a referral from the?
No, not at all. It's just the goal is to make it that what we'll find is that the gynecologist was kind of choosing who should do it. And I'm not sure exactly how they'll choose. Well, in a way. So the goal is that every person who has on that has it. Because I don't think we know what they're going to find beneficial in it. Like I think even if you think you've got a patient that's really well educated, maybe they need that community still. So I think what we've kind of said there is, you don't know what they're going to benefit from. So it should be a blanket referral. So in private gynecologists, it is moving that way. slowly that we're trying to integrate with their clinic. But in the public system, it's quite tricky because someone has to pay for it. And I think that's hopefully where research data will be helpful, that we can show that it's so beneficial to do it, that you get a better outcome, you get less presentations back to healthcare and things like that.
Less complications.
Less complications.
Really
Yeah.
have to work.
And it's less of a burden on, the physios in the public system, the diagnostics departments, all those things that sit in the public system. So,
But maybe have a reach out back and see if we can get our name on that flyer by the sounds of it.
And that's all. Thank you. Thank you. Take some food with you.
Yes.
Yes. Not take it home. If anyone has any questions, we'll hang around for a little bit.
Photo?
Yeah.
Should we get some Spain as well?
Yeah.
Are we getting everyone in the photo though?
Well,
Yeah, I think so.
So,
Everyone stand up. We have to have some people crashing at the front.
what's your name?
Hello, Oh, no, I won't like. I know. I just want to die. Social media. Yeah. Oh, there you go. The three side.
Getting a little closer as well. Beer can, but it's not a beer can. As you know, it's.
Well, maybe a bit so.
Yeah. Cheers, everybody. It's beautiful. Thank you so much. Thank you.
Feel free to take these flyers if you want.
I'm not taking back to bed.
Matilda, this is the poster we presented at the World Congress of Endometriosis.
It's recording.
It's
Next video.